Hi, everybody. Lovely to see you all here today. Could you just move the slide on, Helen? So just to set the context before I hand over to Paul, our first speaker, I just wanted to, for those of you who don't perhaps understand or know, or co-production is one of those words, isn't it, that's out in the ether in the NHS. What does it really mean? So these are some of the sort of elements of what we describe as co-production. And I know that Paul and Olivia will elucidate a lot more on this, but co-production is the ultimate expression of participation. And I guess you could also add to that, it's the ultimate expression of partnership. So in a world where co-production is the norm, then our clinicians and our people who live with the health issues, the carers and the communities that they work with and within would be completely equal. And we know that that's not necessarily the culture that we have in the NHS right now. And if we're going to reach that culture, if we're going to fundamentally change the DNA of the NHS, so that, everybody is an equal, we have to fundamentally change the way that we work with patients. And that's what group clinics are all about. When I set up the experience-led care program in 2009, that was kind of what I was hoping to achieve through the work that we did. And that's why group clinics have become such a massive focus in our work, because they really disrupt the DNA of the consultation, or the clinical appointment, which is at the centre of everything that we do in the NHS. So what we're looking at doing through a group clinic is shifting power. So one clinician for 6 to 8 patients in a face-to-face 10 to 12, that immediately means that the clinician is in a different set of circumstances than they are used to being in, and that has a fundamental impact on potentially the balance of power in the room. It's also about helping people to share decisions more effectively, and understand their options, understand the choices that they have in the context of their own personal experience of living with a health issue. So if you look at the two people, the two partners there in the infographic, on the one hand, co-production really grounds our clinicians and assures that they really keep a person-centered perspective. And on the part of the participants in the group clinic, it means that their lived experience helps them to sharing that lived experience helps them to describe the support and services they need so they can live their life to the full. And they are all experts with an equally valid point of view, working in partnership with that clinician to decide how to keep well and live their lives to the full. And that's another element of co-production. So co-production is also about really meaningful participation. And we think about co-production, and the system is looking at embedding co-production at every single level. And we believe at ELC that co-production really offers a really unique opportunity to embed co-production through group clinics at that interface between how we work with our patients, between clinicians and patients. So that's just to set a little bit of context. As I think Paul will probably refer to it, and whilst Paul's speaking, I'll get the link actually and pop it into the chat. But there is some quite extensive guidance around embedding participation in the NHS, which was launched quite last year, I think it was, or Paul will probably be able to tell us exactly. And working at this level, at this, if you like, micro level, is really exciting to be able to embed co-production in these conversations that we have every day with our patients. So over to you, Paul.
Thanks, Georgina, and thank you also for pushing the guidance. I'll put my email address in the box if anyone wants to write to me directly. Following on from this, if you want to get the word, and of course the author is here today, Olivia, and I'm going to try and give my pitch and then move out the way to let someone who's been operating in this space a lot more than me come in to kind of spread the good word. It's a pleasure to meet you today. So I'm from the People's and Community Directorate. You may remember us in our former guise of experience, participation and equalities. Our role in NHS England is to, well, it's through pointing out to NHS England that through effective and meaningful engagement that brings experience, insight and voice of the community into our decision making in a way that it meets NHS England's duties under the Equalities Act and Section 13Q of the NHS Act is a good idea. And it is where we, the drum that we bang every day. The opportunity we have at Centre is to be an effective evangelist when it comes to innovation through our regional teams. And the privilege we have is to hear so often about innovation that stems directly from communities and involves communities, and you can trace the origin of it all the way back to communities rather than corporate consultants. And it's the potential benefits around these innovations that we ask systems to think about more often when they are designing their commissioning strategies. Now, specifically in relation to group clinics, the potential that we anticipate in this field is where if I can stick with primary care today, is allowing primary care to join more directly, more closely with the community, in the community, to reduce that isolation that some of these groups feel, and to improve well-being in the community. So for primary care, it's that. In relation to systems, it's about not looking to take their ideas into communities that are already operating in this way. It's to get beside them, support them, sponsor them without looking to control them. This is what I think links directly into the phrase that Georgina was using about shifting the balance of power. We know in our roles that we can't really remove ourselves from the power that we bring with us just by the roles and the seats that we sit in. We at Centre see opportunities in group clinics to really do something routinely that addresses that. If we start small with group clinics, if we start with the specific conditions, then what we suspect is that the motor movement of generating that approach to actually understanding an issue, understanding a problem, can become part of the DNA. It can become part of the toolkit in how we approach issues within systems generally. This is the scale that we are talking about from Centre. This is the scale that we're looking to realise as we move into this space in a way where a degree of investment attached. Now, that degree of investment is still to be decided thanks to budgets being realised, but we're really interested in having a look at what's going on and getting beside some good work, particularly systems that see the potential in terms of scale and see the potential in how they change the routine, if you like, about how they go about making their decisions and how they involve people in that decision-making cycle. Co-production, you would trust me to go there. This type of approach we would propose really facilitates good collaboration and production of holistic support for people, particularly if you're in the community, because you're getting into that space that the NHS, not through lack of hard work, but just we know this, we struggle to engage. Now, we have got direct examples of when we get into the community full on with COVID, where improvements start to happen. If we think back to vaccines and testing, when did that change? It changed really in terms of results and attendance from certain groups when we got into the communities and asked them exactly what we needed to do, rather than coming from Centre with a plan, if you like. I think we don't need to do anything, that's the wrong word. It would be good to consider how that approach can be transferred into every other decision that we make. Now, I get it, we're sitting at Centre, we're not fighting on the front line like some of you guys are. Please don't think that I in any way have I come across as patronising. I'm not. I know the struggles that you're under, and I know much of that is created by NHS England, you could argue, in terms of the many policies, the many targets that come from Centre. This is not what this is. This is us asking you to recognize the benefits of your community, to get beside your community, and to think about how you can change how you go about your business, with group clinics being an on-the-shelf solution that you might think about trying. We would obviously suggest, that participating in group clinics routinely opens people up to effective engagement in a way that they begin to trust it more. And of course, that's a bit easier for individuals as part of a group. It's more easy for them to bring their own ideas and what's working for them to a group, rather maybe we would suggest in a direct conversation one-to-one with a clinician. And we know that this is condition specific, and there are many areas where you might not think about group clinics, but we're testing that, and we would hope you would test that, and we're learning all the time, and we need your feedback to help us inform our evangelist approach. But one of the main things that we hope would happen in this space would be the conversation spreading into that wider determinants of health that peer support can bring. And in some respect, chip away at the inherent inequalities that still exist in all of our major conditions, that still exist in almost every aspect of health. Everybody on this call is no stranger to that. Initial results are showing that group clinics really do eat into that. And the last thing I'm going to say, and it's one that NHS England at Centre is really keen to understand, and as we move in our own way to support this development, is this tantalising indication that this could have a really positive impact upon clinician time and A&E attendance. Now, there's more work to do there, but the initial results are good. The more systems that we see adopt this approach, the more systems that we see buy into this as a concept, will generate that sample set that we could maybe think, okay, there is definitely something here. Let's at Centre build our own investment, build our own voice, if you like, and look to increase our suggestion through our regional teams to systems that this is a good idea. Colleagues, it's lovely to talk to you today. I will give way to Olivia to come in and really impress us. Olivia.
I'm not sure I like that degree of pressure, Paul. Thanks very much.
Sorry.
Hi, folks. It's really good to be with you. My name's Olivia Butterworth. As has been alluded to, I did used to work in NHS England. I've just done my year celebration of escape. I'm now working freelance, doing the stuff that feeds my soul and makes my heart sing, which includes quite a lot of work locally with GP practices, with primary care networks, with local authorities, around how they really shift their thinking. My background, if I go back to the age of the dinosaurs, is as a community development worker. So I've worked in communities and alongside communities for a very long time. I want you to think yourself into your community where you live or where you work. And I'd just like you to drop into the chat an example of something you would think of as a community group in that chat. So we use the phrase community groups and community all the time. What is a community group to you? The questions get harder. You can name the group or you can describe the group. We've got representative. Oh, Wonder Woman walking group. I think I might want to join that. A hub where the community can get support, come together. Legosa groups. The girls I play netball with. Place of worship, such as a Gurdwara. Bereavement groups, tea and chat, walking groups, singing for dementia, peer support. Badminton groups, book clubs. Beautiful. So I would characterize a community group as something that is generated from the community that it's serving. It's not necessarily representative because it's self-selecting. So people choose to join the tribe that interests them or that has a shared and common interest. So that could be a mother and toddler group. But one of the big characteristics is it's owned and controlled by that community. They tend to be peer-led. So they're not paid people. They'll be led by people who step up to volunteer in their community. The governance might not be akin to NHS governance because they self-organise. Some of the big examples that people might be becoming familiar with now, Andy's Man's Club. There's a national brand to Andy's Man's Club, but local Andy's Man's Clubs are run by volunteer facilitators for men, by men, with men in their community. Nobody else governs them. They have a very loose facilitation framework that's been developed nationally by Andy's Man's Club. The other one I'll use is Alcoholics Anonymous or Narcotics Anonymous or Cocaine Anonymous. They all run on very similar lines. They are led by people who have addictions, who are supporting other people with addictions. It's peer-to-peer, and there's genuine power sharing. They're not controlled by a clinician. The safeguards are always in place because people do innately safeguard one another, but that might not be the tick box safeguarding approach that we see within structured organisations. If we think about co-production, as Georgina was talking about, co-production is that coming together, producing of something. That coming together, we often see in the NHS co-production being used as a term where we're bringing staff together to co-produce a new service model. Is that co-production? It might be, if that service is for staff. But if that service is for people outside of the organisation, patients, actually they need equitable voice and equal power to shape and design what that service might look like, because we don't share their experiences, we don't live the same lives, we don't understand the barriers that people experience, but they do. And when we get involved in the design of it, we can start to tease out some of those things. So we might determine that clinically appropriate, but it might not be socially or culturally appropriate for the group of people that are not engaging in the clinically appropriate service that we're offering. And we saw that through the vaccine programme. So many people would just refused outright to take up the vaccine. We saw quite a lot of blame from people. Well, why won't they take it up? Well, that's ridiculous, believing all those myths. But when you're a person of colour, and people of colour have experienced medical experimentation over the years, and if you doubt that, there's a really good book about Henrietta Lacks. If you haven't read it, I'd highly recommend it. People of colour have been harmed by the medical profession, so it's not surprising that they don't trust it all the time. And they do believe those generational stories. So there is something about how do we truly get alongside people. This is the bit that really excites me, because the group clinic model is a clinical model that works in a clinical setting. My proposition to you guys is, how amazing would it be if we could make that clinical model work with and alongside existing community groups? And I'm going to use Andy's Man's Club as a really, really good example. So locally, they're all locally owned, as I've said, they're volunteers, but they always meet once a week. And the men who come together, and I've been privileged enough to be invited to the start of an Andy's Man's Club session. Clearly, I'm not a man, I wasn't welcome to stay. But some of the guys came early. And actually, their purpose for being there is mutual support, is learning from one another, is helping one another navigate the systems that we all work in, because they are pretty impenetrable. And when you're not in a good place, they're even harder to navigate. The potential for a local Andy's Man's Club to work with the men who come, and I'm not exaggerating, we talk about men being hard to reach, they don't present early, they don't come to appointments, they don't do this. There were 60 men who rocked up at this Andy's Man's Club on a Monday night, and they're there every Monday night. And they range from the guy that arrived in the brand new top of the range Tesla to the guy that was homeless. There was every social mix in that room, and they all worked together. It was a truly magical experience. If we try to control that, most of those people won't come. But if we get alongside that, and I'm working with some GPs at the moment, we're going to test out and genuinely work with those volunteer facilitators of that Andy's Man's Club to work out what would a group clinic look like that ran before, on a Monday evening, before they start their Man's Club session. Now, it doesn't need to cover the same ground as they cover in the Man's Club, but we know that all those men who are seeking mainly mental health support aren't looking after their physical health. So could there be some physical health clinics? And we're going to do that through conversation and building and working together. There's all sorts of clinical issues with doing it, about patients not being on that GP's list. There's loads and loads of issues. However, none of those issues are going to stop us doing it, because we're going to work through it together and we're going to share why they're an issue with the group. I'm really interested in how many other groups of people who don't access or feel uncomfortable accessing services in a clinical setting, how could that work? So if I think about, I used to work with a group of Bhutan women who met in a porta cabin that had blinds in a school playground. And I used to go along, and they would generally be a health visitor with us and a midwife, and we'd go, and it was brilliant because they are all fully veiled women when they're outside, and they walk through the door of the porta cabin and all the burqas come off. And we had some fantastic conversations. How could that group of Bhutan women become a group clinic to think about the health issues that are really important to that group of women, and who would be the appropriate clinician to go in and work with them? Not to take it over, but to work and be a part of that group. I think there is literally endless potential for this. And it means as a clinician, as a clinical setting, you're not organising a venue. You're not even needing to organise a facilitator, because they have their own facilitators who you would work with around how to facilitate a group clinic. And you've got people that go to them that don't come into the practice, that don't go to other health related things because it's not for them. So how can we really flip that balance of power so that clinicians and other health folk are genuinely rooted in, with and alongside those groups in the population that we are most concerned about? The inequality gap is so huge. And how much as clinicians could you learn from being in their space about what works for them, so you get a payback for it as well? So that's my proposition. I don't think it's been done before. I think there are group clinics that are similar, but not rooted in that community ownership. If anybody's interested, you need to talk to me and Georgina, because we're really excited about the potential of this. We already know that those peer-to-peer groups are one of the most effective health improvements and health management tools that exist. We don't necessarily recognise the value of those within the NHS. But my proposition to you today is, would you be up for testing something like that to see how that could work? I don't think I talked for too long.
You did really well there, Olivia. You channeled your enthusiasm extremely effectively. So I wonder, the next step is for us to have a little bit of a Q&A, but also I think this is a real opportunity for reflection for you guys, and also for you to think about what is going on in your communities. If anyone would like to unmute and sort of share, perhaps some stuff has come up for you listening to Olivia and Paul, and you're thinking, actually, a really big issue for us is X. How could we do something around that? So, I'm leaving it with you. If you want to, and I'm Helen, can I check with you? Can people unmute? I can't remember.
Yes, I think they can.
They can. We haven't stopped them, set it so if you want to unmute and just,
let's see.
Yeah, share your reflections. This is a little bit different to some of our other webinars, because it's very much about exploring. As Olivia says, we people aren't necessarily using the group clinic model the way that we've described today. Usually we have somebody sharing you know, this is what I've done. We're not in a position to do that yet. We're starting a journey here, and we want to work with people who are interested to explore this some more. So, you know, pop your hands up or unmute, and let's talk about this some more.
Georgina, I've just
And if you
checked,
think
everybody
I've
is
talked a load
muted.
of nonsense, if you think I've talked a load of nonsense and you think that could never possibly work, I'd like to know, because I'd really like to know what alarms you about that as a concept, because that's really important learning. Clinicians attending at temples, absolutely. And how could you take that? So that's, I suppose, the supporting some Asian families around diet at festival times. Beautiful. How could you build on that? Because that falls into the sort of the education bracket. Beautiful. How could you expand on that to turn it into a slightly more in-depth group clinic? Thanks for the love in the chat. I really appreciate that. I do get a bit over enthusiastic at these things because I genuinely believe this is the change we need to see.
So, Sue, I know you've got your hand up. Helen, can we unmute Sue or not?
No, I'm unfortunately not
unfortunately.
able to unmute anybody. No.
Oh dear, what a pity. Sue, are you able to stick some thoughts in the chat for us? Apologies. Well, is it worth sending a little message to see if Helena can join us, so we can unmute people?
Sure. I'll send you a message. Yeah.
In the meantime, yeah. So and I guess the learning around the, you know, people going to temples, that came a little bit out of COVID, didn't it, Olivia, where people were, you know, it was like, how can we interact differently with people? There was a really good example of in Haringey. This is the one area where I think they have done this, where they have a very big Turkish population in Haringey, and people were just not going to see the GP for their diabetes reviews, but there was lots of diabetes, so they started to run diabetes group clinics in the town hall in Turkish, so that people could actually, you know, interact in their own language. They had a facilitator who was Turkish speaking, who was able to work with the group, do the facilitator role, and there was a translator for the clinician, and they made huge breakthroughs in how engaged people were managing their diabetes, and were able to bust masses of myths around diabetes, particularly in relation to the Turkish diet, that, you know, ideas people had about what was good, doing them good, maybe what wasn't doing them so much good, and that is on our website, that particular case study. But that's one example which we have tested, and I think there's something really powerful about doing those group clinic sessions in that language as well. Not to, at least because it, you know, also saves masses of translator costs, because the only person who actually needs a translator is a clinician. So that changes the power dynamic massively, doesn't it? So Sue, you're saying you're delivering one-to-one health promotion appointments on a bus. Okay, for all the drivers. Could you imagine group clinics working for that? Absolutely. Really good. Yeah. And also, I mean, what's one of the things I was telling Olivia about this? I had, very sadly, last year, a friend of mine who was a gentleman who's 60 years old committed suicide, and I was absolutely horrified to learn on the day of his funeral, because I did a little search on the statistics, that the highest level of suicide in men is between ages 45 and 65. And I just couldn't believe that was the case. And I think, you know, being able to get people to be in a safe space in a group, you'll be so surprised how topics that might seem taboo somehow seem to be easier to talk about in a group. We've seen this with menopause as well. You know, talking about issues like vaginal dryness, you'd think, oh, nobody will want to talk about that, but somebody mentions it, and the facilitator makes it okay to talk about it, and suddenly everybody's nodding and going, actually, that's something that I'm dealing with too. So ironically, groups can be great at bringing to the surface topics that are, may otherwise not come up. Any other thoughts, guys? I'm sorry that we can't unmute you for at the moment.
Georgina, I've checked with Helena. Even though everybody joined muted, and that's how we set it up, apparently they can still unmute themselves.
Okay, so just Sue, have a go. See if you can unmute. Yay! We can see your lips moving, and you're not unmuted, but we can't hear you. Hello.
Can you hear me? So
yes,
sorry.
I can. Yes, okay. So it's working. Perhaps go ahead. Go ahead.
Right. Okay. Sorry. I think I did put it on the chat already. One of the key thing I'm interested in. I'm a pediatrician, and I'm interested to see how this can be really brought into pediatric specialties, and especially community pediatrics, where a lot is related on the group education and sharing the information to the families. So I do feel there is a great opportunity, but how do we really make it happen, or where we can ask for a support for the organizations, or because it's a new concept, and I do feel we can bring a lot of waiting times, but can be more effectively, rather than giving the same advice to every child and a family in the clinic.
Yeah,
we could do that through that kind of a model that you explained. So how do we move forward with this? And particularly, I'm looking at the chronic sleep management.
Brilliant. Okay, so just pop your email in the chat and I'll pick up with you afterwards, and we can have a talk about how we can pick that up with you. Whereabouts are you actually based?
I'm in Bristol.
In Bristol.
ICP, yeah, Bristol, North Somerset.
Okay, fantastic. Well, we'll pick that up and have a talk with you. We have got quite a few pediatric models that have been tested. So people have looked at viral induced wheeze in respiratory. We've some really interesting work around sickle cell anemia and group. I don't know if you know anything about sickle cell anemia, but families are often very reluctant to even tell their relatives that their child has got sickle cell. And an amazing community nurse set up sickle cell group clinics for babies, and the I don't know what's the right word, the social capital that they created by connecting parents having to come to terms with having a child with sickle cell and reducing the stigma was literally, it's actually making the hair stand up on my arms even just thinking about it. This is so powerful potentially.
Thank you.
I'll pick up with you on that.
Thank you.
Anyone else want to? You're all empowered to unmute. Stephen.
Hi.
Oh, sorry, it looks like Stephen,
Stephanie.
but maybe it isn't. Stephanie. Just saw the
STE. Well.
Stephanie.
I'm very sorry if I've missed it because I couldn't join the whole thing at the beginning, but I'm thinking of, we're in the process of setting up a group clinic, hopefully for menopause in our enhanced access service. And this was really to understand how we take that forward. You talked about kind of having robust consent forms and things in place. Is there any sort of support we could get our care coordinators start to get those prepared? Any sort of templates we can have a look at? That was my first question.
Sure. Stephanie, are you in Leicestershire?
In Leicestershire, yeah.
Yeah. So if you put your message, put your email in the chat, we already have training funded in Leicestershire, so we can potentially get you access to a training package to help make this a lot easier.
Yeah, that would be great. And I suppose that would probably also answer my second question, because as a clinician and sort of prescribing, what the sort of experience is when you go away prescribing separately for the individual patients, how that really works. But I suppose your training package will
It does indeed. Yeah, we have advanced skills training for clinicians, and it's exactly that kind of thing. How do you, change medication in a group? How do you document? All that kind of stuff is covered in that. So yeah, just pick up, because we've had that training for that funding for a little while, and it'd be amazing to work with you. We've also got loads of examples of menopause group clinics happening all over the country, and we can help you to think about the design of those as well. So anyone else want to unmute?
Can I
Thank
just
you.
pick up on Nicola's points, Georgina, around the challenge in geography, particularly in rural areas? So, Nicola, you're in Devon, and the connection into secondary care pathways. For me, there's something about if you look at neighbourhoods, the geography isn't a challenge. It might be a challenge to professionals, but people live in communities. And actually, some of this, the scale of it, is small enough that it would work in a neighbourhood. It works, and if you look at sort of local people's networks and how they manage transport-wise, we make it really hard for them to get to NHS settings because our settings are increasingly distant from the communities that they live in. There is something about really knowing your patch and thinking, okay, well, there's a village hall there. What's going on in the village hall? What's going on in this space? What's going on in the school after hours? Nicola, come in and talk to me.
Yeah, no, I couldn't agree with you more, Olivia, in the sense of yeah, in North Devon we have one communities, so there are multi-professional kind of organised events, if you like. So they have a coordinator, and they know everything that's going on in their community. So each of the main towns has one. So all of that stuff happens. I guess I guess we've come into this on the secondary care front rather than from a primary care point of view. So it is much more about the secondary care coming into the communities, not at all from the community's point of view, and just the small numbers of the population is there, the volume there then to do the pieces of work. And it's very much about scoping it out and spending a lot of time working out, is it viable, does it work for everybody that's involved, really. So I think whereas you've got primary care settings, I've been doing some population health management programs where you've got multi-professionals in primary care, and you can do they're in those communities, they're connected, it's very different, whereas ours, we've got one main hospital that covers it covers North Devon right down to Exeter. So it's the travel distance for a clinician is about an hour and a half. So we have to be mindful that it will work wherever we put it, and it has the best value.
Yeah, you've also made me sparked another thought with me, Nicola. Sorry, this is what I do.
That's all right.
I get ideas and I get excited. There are so many peer-led online groups that exist. So if I think about the work I've done with children and young people around mental health, there are huge parent carer forums online who draw from huge geographies. Again, not been done before, but my goodness, it'd be worth exploring. What would be the potential for a group clinic model to work in that context?
Well, we have actually done
Georgina's going to say they've done it.
We've done loads. I mean, the training that we have, Nicola, and we are doing some work in Devon. So I would really drop me again, just to say you're happy for me to pick up. Send me an email in the chat. And video group clinics do work really, really well. And one example of a piece of work that was done in Wales, which has similar geographical challenges, obviously, to Devon. They actually ended up saving something like 7 hours of clinician time for every video group clinic appointment that they did, because it was the travel time for 2 different clinicians to go and see patients who lived in some cases 2 hours away from the hospital face to face in one-to-one appointments, and they saw them instead in a group clinic. And they also massively reduced the need for those patients to have input from nurses. This was an oncology intervention, and consultants said that they were getting far fewer questions from patients, and patients were much more empowered. So I do think that we can be really pragmatic. I was really, really skeptical about video group clinics before COVID, because I thought I couldn't see how you could create that same environment online as you do in a face-to-face environment, but actually with some really simple tools that Helen has demonstrated earlier today, I've seen magical video group clinics, literally people's, you know, perspectives transforming and people feeling so listened to and understood because they were meeting people for the very first time who were, you know, living with the same condition as them. Nicola, do come back.
Yeah, it's so the other compounding factor or other factor is technology and the use of the internet. So, for example, we were doing a piece of work around chronic pain and we had a patient representative. They had no computer, they had no access, they had a mobile phone, that's all they had. So they do work well, absolutely, totally on board. And again, we'd have to just then scope and understand, can we be inclusive as we do it?
Absolutely. And so do pop into the chat if you're interested in picking up, because our trust, your trust is involved in the Devon work that we're doing. So if you're interested, it might be a real opportunity to get access to training and stuff.
And there's another interesting one along those lines as well. Veronique's put in about having a video group clinic set up, so you might have the clinician online but the facilitator and the group in a room. So it could be in a village hall, a community hall or whatever. There could be something quite interesting to explore there. There's also something about, and I think a lot of social prescribers have been doing amazing work around this, is how do you digitally enable people who don't have the kit? So often social prescribers will know that there are digital inclusion projects locally. So I know there's one relatively local to me where actually people get referred to it and they get kitted out and they get taught how to use it. Don't ask me where it's funded from, I haven't got a clue. But there's local businesses involved in it and all sorts of stuff. So I'm not saying these things are everywhere, but there are different areas of the country do have different digital inclusion projects. How could you lever some of that in? And your social prescribers probably know what's already going on. And then the social value add there is enormous because you're enabling somebody to participate in a digital world that's previously been out of bounds to them, which could have massive benefits beyond the specific health issue, but thinking about the loneliness, isolated, housebound, lonely people that somebody else mentioned, the potential there would be enormous of digitally enabling people to participate.
Absolutely, it's part
Georgina,
of the way. I know you're going to interrupt and
put me in charge of time, and I will always monitor it.
I know. I was just going to add to that digital inclusion it causes inequalities in all parts of your life. So if you can use video group clinics to overcome that, that's a real win. But and Helen, I'm handing over to you now.
Well, thank you.
Control me.
I was thinking, how am I going to get in between Olivia and Georgina here with their passion? I have popped up a slide with our next few months worth of